And please go ahead. Great. Thanks, Jeff. I'm just going to get this up here again. Good. So thanks for the invite, Jeff. And I'm just going to start a timer here on my phone so I can keep a little bit track of my time. So thanks for the invite. And it's a little bit different approach than what we've done traditionally. Usually we've had these year-end summaries that we do in May every year. We kind of look over the past year in the Heart Center, see what we've done, how many cases we've done, complications, length of stay. But what I thought to do today, in addition to talk a little bit about that, is to maybe just talk about how the cath has, excuse me, has evolved over time. And I'll kind of really relate that mostly to how it has evolved since I've started practicing here in St. John and since I completed my training. So these are some of the objectives I'd like to kind of go over with the case. I'm going to briefly talk about PCI, but I'll spend a bit of time talking about imaging and physiology and how that's become certainly a more important and really essential tool in the cath lab currently. I'll talk also about management of calcification, because this is a challenge that we face in our cath lab, and we definitely have better tools now than we've ever had before, and perhaps most importantly, a better understanding of how to use these tools and who to use them in. And I think these topics will lead in nicely to our CHIP, or cardiac high risk indicated patient cases. People are high risk interventions, and how we manage those patients, and what we've been doing here at the Heart Center. Towards the end of the talk, I'll talk about structural procedures and briefly to talk about how many we've done here, and spend a minute or two talking about TAVI, because that's the big structural procedure we do that's led to great growth and great outcomes here at the Heart Center. So as a lot of us been around for a long time, PCI has evolved over time and changed. Began out just a simple ballooning a vessel, or POBA, plain old balloon angioplasty. That was first done in the 70s. Stents got introduced in the early 90s, and I think people who were there when they first got introduced realized that this was a critical component of managing people with coronary disease. If you can do intervention, they had a rapid uptake. And then in the early 2000s, we had the introduction of drug-eluting stents. And now currently we're in our third generation DES with bioresorbable polymers now. So that thing has evolved, and those things haven't, the DES has been incremental improvements over time, but we have such good stents currently. It's hard to imagine how our stents are going to get much better in the future, other than minor incremental changes. So that the technology and the safety of them has become so good now that any changes will be incremental. So I'm just talking a bit about what a cath lab was like when I finished my training, and then I'll kind of talk about how the status currently is in our cath lab. When I finished training in 2004 in Ottawa, the cardiac catheterization was pretty straightforward. I felt it was just diagnostic cardiac cath, people with coronary disease, which takes up the majority of our patients. Valvular disease, a significant number of patients as well. And then we had less common things. We do cardiac catheterization for people with cardiomyopathies, a small number of people with aortic diseases, and then even a fewer number of people with congenital heart disease. So really that was the bread and butter of the diagnostic cath lab. We spent a fair bit of time calculating valve areas, complicated mathematical equations, calculated errors, but that's gone a little bit to the wayside now, because we have such good imaging techniques with echo, TEE, and even CET and MR for assessing valvular disease. So although that's an important role, what we still do, that has become less important as our imaging has gotten better. When you do interventions, when I completed training, really it was relatively straightforward. It was just PCI for acute coronary syndromes and stable coronary disease. You had a relatively small selection of wires, balloons, and stents, and you didn't really need much more than that, other than a good nursing staff, good imaging chain, clinical perfusion, and surgeons to help you and back you up and bail you out if you've got any problems. At that time, there was really limited structural heart disease interventions. Really, the interventions at that time were just beginning, and really consisted of PFO and ASD closures and mitral valvuloplasty, which had been done for decades before, but that really had not changed for many, many years. Really just the beginning of the kind of introduction of some structural interventions. But imaging really has become a key component of having a full service cath lab currently. And the imaging technology we currently use are intravascular ultrasound and optical coherence tomography. So IVUS, which has been around for a long time and was around in my training, but really was not commonly used. I probably, out of 900 cases that I did, I might have been involved with less than 5 IVUS. So really was something that was not used commonly, we weren't trained in, and really was more of a research tool at that time. But that has evolved over time, and IVUS become a key imaging modality, especially for assessment of indeterminate lesions, especially left main and proximal LAD, circ, RCA disease. Very helpful for looking at osteal lesions where angiography is very limited and can't give us good views. Very helpful for risk stratification and PCI planning, looking at the degree of calcification, vessel size, and also we're useful pre and post PCI to make sure we've optimized our stent deployment, optimized our intervention. So, and this has become used more commonly because the data to support it has become more common. There's good data now support that IVUS guided intervention leads to less restenosis, less stent thrombosis, and overall better outcomes, certainly when you use it in selected patients. OCT has a lot of the similar abilities as IVUS, not all of them, but certainly, but doesn't have quite have the data to support its use as much as IVUS, mainly because OCT hasn't been around as long. It really was just introduced as a research tool in 2014 and has undergone incremental and pretty rapid improvements since then to now to be a very well-refined technology that gives us excellent image quality. This is just a still frame of a reason or a case where we might use IVUS. At the top left of the screen, you can see a still frame of a left main on the top left part that has some disease distally, but doesn't look that bad. But if you actually do an IVUS image on this patient, because perhaps you were suspicious because they had a high-risk imaging study, stress imaging study showed a lot of anterolateral ischemia, you can do the IVUS, you can see the frames in the middle of the bottom of the screen. You can see a really tight narrowing of that distal part of that left main that you really don't appreciate angiographically because we're limited by our views in a two-dimensional views. But if you truly look at that lumen, you can see in the middle of that bottom frame that is a tight narrowing, and that would either warrant some kind of vascularization strategy. These are an example of the OCT images, which really give excellent fine detail quality near lumen. And you can really see that coronary anatomy extremely well with these images. And these images involve injecting contrast and doing your OCT at that time so the blood is not there. So you get great image quality. You can see the intima, media, external lamina, and really get high quality resolution. And this degree of resolution can really be helpful in terms of diagnosis and intervention planning. You can identify whether a plaque is fibrotic, full of lipid, if there's a lot of calcium, or severe calcium, because that will actually potentially change your strategy for intervening upon on certain patients. It's also helpful from diagnostic point of view. If you see the bottom left image, you can see dissections. You see that large black area right around here from about 6 o'clock to 8 o'clock. That's a dissection in the intima. And you can see another dissection up towards 2 to 3 o'clock. And then you can see a medial dissection, and that's in the second image beside that. On the bottom right corner of the screen, you have a stent deployed, but you can see where that stent actually isn't deployed against the vessel wall. You can see a gap between those stent struts and the wall. So this high quality image really lets you optimize that stent deployment. You would go back in there with a bigger balloon and really inflate that stent so it's pushed against that vessel wall to ensure it heals better, reduce the chance of restenosis, and also decrease that chance of stent thrombosis and subsequent adverse events. And the technology for OCT really has come a long way, even since it's been introduced. The software really detects, can give you an automated deployment percentage to see whether or not you've optimally deployed your stent. And if the computer or the software tells you haven't deployed it, you can go back and post and deploy that stent. So you can measure how long of a stent you need, see how well you've deployed it, size it correctly, look for proximal distal edge dissection. So it's really extremely helpful in selected cases. Physiology assessment has been around for a while, but again, when I first trained, it really was a research tool and not didn't really have good data to support its use. But over time, that has changed. And physiologic assessment is relatively straightforward. It's just a matter of measuring the pressure distal to a lesion. As you see, you have a wire with a transducer on it. You pass it by a stenotic lesion. You measure the pressure distally. You create a ratio, compare with the pressure proximally, and then you can get a value to see whether or not a lesion is significant. The pressure wire X is the wire that we use most commonly here now. And this has evolved over time. It's completely wireless. You turn it on, you flush it, you insert it, and it's ready to go. And it's very user-friendly now compared with when it previously came out. And we've got great supportive data for the use in patients now currently. If we have an FFR greater than 0.75, we can be quite confident that it's safe to defer an intervention. And if actually you're doing intervention on an angiographic lesion above 8, we know that we actually may harm people. The converse of that, if we have an FFR less than 0.75, we should intervene upon that patient because we can know we can reduce future events. And in comparing optimal medical therapy with intervention, we know that if you have a significant FFR, you can get better clinical outcomes at 3 years. So we have good short-term and longer-term data to support the use of physiological assessment of coronary for intermediate coronary stenoses, and sometimes angiographically not intermediate. They look severe, but we're not sure because the patient has no symptoms or a normal nuclear study. So certainly very helpful in managing patients. So our current use of imaging or physiology at the heart center, IVUS or OCT is probably at least 5% of our total cases, and I'm estimating a bit here, probably around 9% of our interventional cases, which is a reasonable number. Probably we could do more in terms of interventional cases because, certainly if you were in Japan where IVUS and OCT is used very often, you'd be using them up to 70–80% of cases. So that has grown over time, and I think will continue to grow. But that's probably a reasonable assessment of the current practice in most centers. Physiological assessment, you use about 6% of cases. And I'm not sure exactly how many of those cases turn into interventions, but again, it's a very useful tool, especially in patients who come just with an abnormal stress test, but no imaging to go with it to help guide what territory or vessel might be causing their ischemia. Calcification has always been a challenge in the cath lab, and we're often limited in how crossing these lesions and actually fracturing that calcium and being able to deploy a stent. And we have multiple tools there now that are at our disposal. The rotational atherectomy has been around for a long time, but we have a new iteration that was released probably about 4 years ago. And it's pretty straightforward. It's just a diamond tripped drill that you place on a wire in advance, very high revolutions, about 180,000 RPMs. And you basically tap that or drill that through that coronary stenosis, that calcification, and to create a channel or an adequate sized lumen so we can pre-dilate and deliver stents. Intravascular lithotripsy is a newer technology we have for about a year now, and very similar technology to the lithotripsy used for kidney stones, but certainly it delivered very locally in a highly specialized fashion. The beauty about this technology is it's easily doable or translatable into people who may not have any experience with managing calcium with rotablation or oral atherectomy. So the balloon is very similar to what we currently use. You have these two emitters that generate ultrasonic energy and fracture calcium, and it's done in a very similar modality than any type of intervention. And in the top left part of the screen, I'll go through this quickly. You can see a lesion on the top left pre-procedure. This ring around the vessel is all calcium, this darker ring. You do lithotripsy, and you see the middle screen that all that calcium is fractured, and then you see a much larger lumen once that stent is deployed. So this really lets us fracture that calcium to deliver those stents and optimize our intervention. of what all these technologies and newer and some older treatments have allowed us to do is to manage a lot of these more complex comorbid patients that we see with a lot of challenging anatomy and a lot of significant comorbidities that sometimes are prohibitive for surgery. And this diagram really kind of illustrates the type of patients we're talking about. We're talking about people that are high risk, so they have a lot of comorbid illnesses. They may have poor LV function, high elevated filling pressures, and they can have very complex anatomy, and these often overlap. So these are the patients where the heart team really approach really comes into effect, is really beneficial. We often, or almost always, have the surgeons involved in these cases, the attending cardiologists, interventional cardiologists, and all our supporting staff in dealing with these patients to really look at the anatomy, look at their clinical characteristics, and try to optimize the best way to manage these patients. And some of these clinical factors we see are vascular disease, diabetes, end-stage renal disease, acute coronary syndromes, again, people with low EFs, high filling pressures, and very complex anatomy with calcified tortuous lesions that can be very long, or left main bifurcation, trifurcation lesions that can be very challenging to treat percutaneously, but equally sometimes very challenging from a surgical point of view, not necessarily from an operation point of view, mostly from the risk of these patients. They often have comorbid illnesses with lung disease, renal dysfunction, pulmonary hypertension, very frail in that you can do an operation, but whether or not they recover well is clearly the limiting factor. And again, calcified aorta, which we can see occasionally. So this is kind of a scoring system. I won't go through this in any detail, but as you can see, the increased number of clinical factors from patients and procedural factors, the risk of major adverse cardiac events goes up with time. And clearly, I think what's happened over time is we've gotten better at these complex patients. We have these better technologies for managing calcium. We have better imaging modalities to optimize our intervention. The number of chip cases we've actually done over the past 4 years has gone up with time. Whereas in 2019, when we first started tracking these, we did about 29 of these cases, but we did close to 90 cases over the last 2 years. And if we kind of project out the number we've done so far this year, we'll probably get close to 100. So again, these are complex, high-risk cases that after discussion with the surgeons and attending physicians, we decide that the safest way to revascularize these patients is with a percutaneous intervention. And I suspect this number will only increase with time as we get better at it and we're able to better identify these patients. What this has also led to is doing really extremely high-risk interventions in patients who need hemodynamic support during PCI, which is an entirely different topic. But as you can see, we've starting doing these in 2019, where we did 1 case. And if I project out to what we may do this year, we're probably getting close to 20 cases per year. So this is where we really need ECMO to support this intervention, because if we have any complication during PCI, that patient won't survive. Should be noted that a lot of these things are clearly very labor intensive and take the expertise of multiple people to pull off and can be quite time consuming. So I'm going to shift to structural disease very briefly before I kind of come to our few summary slides. So the structural disease has only grown since I've completed training in 2004. And probably the biggest change has been with transcatheter valvular therapy, and TAVI being the really big topic. Mitral clip to a lesser extent, and the adult congenital therapies such as ASD or PFOs to a lesser extent, but again have been well defined and refined over the past 15 to 20 years. Currently, we've done 22 cases of AFC and PFOs over the last 2 years, and I believe we've done close to 10 mitral clips over that same period of time. So clearly a much less common procedure compared with our TAVIs, but certainly comprise a significant component of our practice and treatment of patients that we see at the Heart Center. This is just an illustration of how TAVI volume has gone over the past 10 years, from when it started in 2011 took off quite quickly. We had 3 or 4 years where it's flat, gone up again from 2015 to 2019 was relatively flat. And now as we see more patients, as we're doing more moderate risk patients and lower risk patients, if we project it from, this is the calendar year to the end of March, this slide here, but if we project, the fiscal year, if we project it to the calendar year for this year, 2022, we're very likely going to get to 200 TAVI per year. And hopefully we'll start to see a plateau after that point in time. But that volume has clearly gone up, and I feel it's a testament to the strength of the program and the physicians and staff involved in that. We've got such great outcomes. If we look actually at the total number of cases we've done in the cath lab per year, it's actually remained relatively stable for 10 years. Despite the challenge of the pandemic in 2020, 2021, we did manage to have our second largest year last year, doing just over 4,200 cases. But the total number of cases in the lab have actually remained quite stable. What has changed is we're doing more complex procedures, more time-intensive procedures such as a TAVI, as you can see here, and we're doing more of those chip cases. Our total interventions probably is around about 1,900 per year, and that has again remained relatively stable. So what has changed and how has the cath lab evolved since I finished my training and I've come to the Heart Center? It's, our interventions really originally were all angiographically guided with supporting non-invasive testing with stress echo, stress nuclear studies, but really we're guided by our angiography and really didn't use physiology or other intracorneal imaging. Now in 2002, we have to have angiography supported with adjunctive tools. You need FFR, you need intravascular ultrasound, you need OCT to be a fully functional cath lab currently. Our hemodynamic support tools back in 2004 were pretty limited, really just balloon pumps. Now we've got ECMO, we've got percutaneous LVADs, and a myriad of other hemodynamic support devices to help support our interventions. Our structural procedures really in 2004 were pretty limited to SD, PFOs, and mitral valvuloplasty, but now I can't list them all, the number of procedures that are being researched and developed over time, but TAVI clearly has taken off and is here to stay. We'll only get more so with time. Left atrial appendage occlusion devices will come on board probably within the next few years. Mitral clip, ASC, and PFOs will always be a small number of those, but always be a skill set that we need to have. And I think perhaps what's most important has changed our approach to these patients. Whereas 2004, although we had our multidisciplinary rounds discussing patients, we probably largely operated in silos. Whereas now we really have very comprehensive teamwork with the entire heart team, with the surgeons, cardiologists, interventional cardiologists, electrophysiology, and highly trained nurses and industry support when we manage these complicated patients. So it's really been an evolving case over time, and really the cases that we are doing now in the cath lab complex interventions, when I did my training, I'd say there's no way we're going to do this. You're crazy. Whereas now we're doing these things and we're doing them safely because we've got these great technologies and support to do these interventions. So what do I see going forward? I think our bread and butter still is the bread and butter diagnostic casts and straightforward intervention, but the structural disease, the chip interventions, more complications will take up more of our time and effort, not just interventional cardiologists, but the entire cardiac team. But as we do more of these patients, we get better at them and we have great outcomes with these patients and good outcomes. So that's the benefit of doing more of these cases. You get good at them and you get great outcomes. I'm just going to stop right there, Jeff, and leave it open for any questions anyone may have.
Perfect, Colin. I'll ask you to stop sharing your screen so that I'll see the people open for questions for people, and I'll start. I think you pointed out to some of the challenges, Colin, to the bread and butter sort of things are maintaining their numbers and their volume, but clearly there are other things that are growing. and they're time consuming and complex. So in your mind, what are the current sort of biggest challenges or sort of the barriers to achieving that in the short and long term, as a heart center and obviously as a province that we need to sort of think about?
Yeah, so I think to if we're going to kind of move forward and deal with these, challenging cases and increase truck involvement, you're going to do, I think the challenge we have is human resources, as we all know, especially I think the human resources challenges are huge in terms of, especially as we've seen over the last few years in delivering these more complicated procedures. I think the challenge we have and what we need to go in the future when we recruit new people, a physician, I think of physicians specifically, I don't think we'll be looking for people who are bread and butter interventional cardiologists anymore. I think we're going to need people like me, who is a bread and butter person. We're going to need people who have more specialized training. As whereas I did a one-year fellowship, all the fellows now are doing 2 years. And I think the longer training in a more formal program will give them opportunities to be involved with either structural interventions or chip kind of high risk interventions. So I think the current training opportunities are there, and that's what we'll be looking for. Human resources will be a big part of that. I think the challenge is also space requirements as well. I think hybrid OR, where a lot of these structural interventions can be done and probably should be done, is the way of the future. Not necessarily in the heart center alone, probably in every operating theater of any size. This is going to be the future, not just for cardiology, for urology, orthopedics, other surgical modalities. So I think a hybrid OR will be very important to help address these issues and deal with these more complex patients going forward.
I wonder too, from a staffing point of view, if a hybrid sort of OR, you could imagine staff that would actually be able to do surgery, PCI, interventional radiology as support staff, this sort of cross-pollination of expertise. Mm-hmm. Anyways, just one of those dream things that you have in your mind, in my head anyways.
I think we're unique in that here where we have, deep involvement with the interventional radiologist with our TAVIs, whereas no centers do not. I think that skill set has really, again, cross-pollinated. Like there's things that the interventional radiologists have managing patients that we're not aware of and we've never seen, but that has bled into our coronary practice, whether it be vascular access issues, percutaneous closure of vessels, larger balloons, stiffer wires. They have a lot of tools that they have there that we generally are not exposed to when we're not exposed to during training. So I think that cross-pollination is very important, and it's been very beneficial.
Yeah, they've helped, from a percutaneous point of view, from a cannulation for ECMO and all of that have been very helpful with closure devices, avoiding incisions, those kinds of things have been tremendous. And on the TAVI program, as you know, has been a big deal. So before we close, there is a question around MitraClip, and just to educate everyone, is yes, the MitraClip program is still running. Brent is our structural valve expert and is championing that. And for myself on the surgical side, so we did 2 last week. We are reviewing patients on a regular basis, and so please, considerations for that. And also, if maybe the last question that comes from Sumaris as we're hitting the 8:30 is around simulation and your thoughts around, in the CHIP sort of program or these high-risk cases, is what's your thoughts on simulation and preparing in those type of cases?
So there is certainly a lot of the companies have simulation labs, and if you visit some of these centers, I visited Boston Scientific a few years ago, and they have a dedicated simulation lab in their center. What I think would be perhaps ideal or good for us is if we can get either our own simulation lab or experience in a simulation lab, perhaps not so much as we currently practice, but more so when we are training, because these cases don't always come up during your training. But I think if a simulation lab, like a lot of other things in medicine, will play a more important role. So I think that that will play a role. How that will play out, it's hard to know. I think it's a bit of a niche at the heart center, and heart centers to have your own simulation lab that may not be used a lot, but I think the resources do exist, especially within companies to have simulation labs.
All right, so with that, we're going to close for today. Thank you again, Colin, for the great presentation.
Thank you,
Next
everybody.
week will be Dr. Toll on electrophysiology department. So thank you very much. Have a good week. Bye-bye.
Thank you.